Hi class, welcome to the online discussion on general pathology. We are now with the second leg for the neoplasia. This would include slides for the mixed tumors as well as for the malignant epithelial tumors. So we are going to start with 219, that is fibroadenoma. We have 196, that is Wilm's tumor. Slide 88, cystic teratoma. Slide 14, cervix in situ. And then slide 70, this is invasive squamous cell carcinoma. Slide 187, basal cell carcinoma. And 188, that's malignant melanoma. There's another slide, that is slide 152 for squamous cell carcinoma, which we are going to tackle along with slide 70. Okay, for slide 213, unfortunately, what I have here in my house would be not so good slide, so I'm going to get one slide tomorrow for the discussion. So let us start with slide 219. This is fibroadenoma. This particular tumor is a benign tumor of the breast. We only see it in the females. Its male counterpart would be called gynecomastia. So it's only found in females. So fibroadenoma is seen more commonly in the 20 to 30 age bracket, but it can be seen in other age group. It is fairly circumscribed. It is nodular. It is firm. And histologically, as what you would see here, you would see the presence of dilated ducts and ductules. These are the ducts and ductules. And then it is surrounded by abundant stroma. So this is a feature of this particular slide. We would see the presence of abundant stroma. It can be fibrocollagenous like this portion. It can also be fibromyxoid like this portion. And notice the ducts and ductules here are being compressed. Okay? So they are being compressed into slit-like structures. So they are compressed by a lot of the stroma. This is very typical for fibroadenoma. So this would be falling under proliferative change without atypia. So again, this is a benign tumor of the breast. Okay. So our slide next would be Wilm's tumor. So Wilm's tumor is a malignant tumor that is the most common type of malignancy found in the kidney in children and in infants. Okay, so we do not see it in adults, or very rarely do we encounter it in adults. I have not yet encountered it in my practice, so most probably this is very rare if it would occur. This is associated with a WT1 gene mutation, and histologically we would see three components present. Okay, so three components would mean stromal, epithelial, and blastemal. Blastemal is B-L-A-S-T-E-M-A-L, blastemal. When you say blastemal, it would be composed of small round cells. So the Wilm's tumor, because it is found in the younger age bracket, they would fall under the small round cell tumors, like the cells that we have here. And the components, okay, because that's why we call it as triphasic, because we have the blastemal component. This would be the blastemal component, wherein you would see clusters of blast cells. And then we also have the epithelial component. Notice that the atypical cells, the small round cells, are forming tubules, okay, tubules or gland-like structures. Okay, and lastly would be the stromal. So when you say stromal, there's a lot of the stroma surrounding the small round cells. So this is what we call as the Wilm's tumor. Okay, so again for Wilm's tumor, very characteristic would be the presence of small round cells. They would be forming three components. We have the epithelial, we have the clusters, dense clusters of small round cells, which we would call as blastemal, and then we also have this stromal clusters, which would be stromal component. So the genetic mutation would be WT1 gene, and this is found in the kidney. Next we have slide 88. This is what we call as the mature cystic teratoma. Okay, so slide 88, we commonly encounter this one as a cyst, although there are conditions wherein it can be seen as a solid mass. So it's a benign tumor. It is teratoma because it is derived from the 3 germ cell layers. If it's derived only from the skin, from the ectoderm, we may call it as a dermoid cyst. So because it's a cyst, there would be some material present within the lumen. Usually we encounter here, as well as the presence of sebaceous material. So grossly, microscopically, we would see the presence of the lining epithelium. In this case, it's stratified squamous epithelium. Okay, and then we also would see or appreciate the presence of adnexal structures. Like in this case, we have the sebaceous glands. Okay, so there's the sebaceous glands. We also have here the mucus acini. And then we have here the cartilage and fats. So this is a mature cystic teratoma. In 1% of cases, it can undergo malignant transformation. Okay, so usual area would be the ovary, but it can be seen in any part of the body. Now we go to slide 14, which is labeled as Cervix Carcinoma in situ. Okay, so now we know that this is coming from the cervix based on the label of the slide. Okay, and we start with the review of the lining epithelium of the ectocervix, or the outer portion of the cervix. So the lining epithelium would be a stratified squamous epithelium like this one. And we always would look at the maturity of the tissue. Okay, so what have we learned with my lecture is that we would see the basal portion, this is the basal layer, to be composed of immature basal cells. So when we have immature basal cells, they are the ones with darker nucleus and with scanty cytoplasm. With the normal stratified squamous epithelium, we would see the upper levels to have increased amounts of the cytoplasm until such time that it would be present in the stratum corneum, and they appear to have a very small nucleus and abundant pink cytoplasm. So that is what we call as the polarity, or there's maturation or differentiation of the lining epithelium. So in this case, we can go to the area to which we are concerned of. So in carcinoma in situ of the cervix, it means that there's the presence of the malignant cells occupying the entire thickness of the epithelium like this one. So this is what we call as carcinoma in situ. With regards to the cervix, it is part of the CIN, or cervical intraepithelial neoplasia, wherein it is classified based on the involved portion of the lining epithelium. So we have the cervical intraepithelial neoplasia 1, 2, and 3. So if there are atypical cells, which normally, if you remember right, there's a presence of immature basal cells in this particular area, the basal layer. However, if we have atypical cells as big as this one or this one, then these are identified as dysplasia. And when you have dysplasia in the lower one-third, so you have to divide this lining epithelium into 3 parts. The lower one-third is occupied with atypical cells. We call it as CIN1. If the atypical cells occupy the lower 2/3, we call it as CIN2. And if you see the involvement to be full thickness, then you call it as CIN3, or we call it as carcinoma in situ. The only time that we would call it as an invasive carcinoma is if we would see the presence of invasion. Okay, so this is still carcinoma in situ. You might, in some of the slides, you might be able to see something like this one. Okay, wherein this may be a stromal invasion. Okay, so in carcinoma in situ, it is common for us to see a metaplastic event like this one. Okay, so there's a metaplastic event that is found involving the gland. So instead of having squamous cells, you would see atypical squamous cells, okay, involving the glands. This one also. So this is also a metaplastic event, but this time you would see the presence of the atypical cells. So this is still carcinoma in situ. So next we have slide 70. This time, the carcinoma in situ here would progress. Okay, so it becomes an invasive component. So when you have squamous cell carcinomas, it would mean that we would see the presence of the so-called nests. So nests are clusters or aggregates of atypical cells that would be seen invading into the stroma. So these cells are examples of squamous cells. So we would be able to identify that these are squamous cells, okay, if we would see the presence of keratinization. This is difficult to identify in this case, but you have to look for the presence of the pink cytoplasm, okay, or orangophilic cytoplasm, or the keratinization. There is also one thing that we have to look for, and this is the presence of carotene pearl. Okay, so carotene pearl, it means that there's the presence of a concentric lamellation of keratin with entrapped glands. So this is what we call as the carotene pearl, and it signifies that this is a well-differentiated squamous cell carcinoma. So other features for squamous cell carcinoma is you look at the adjacent cells. Notice that there's the presence of these junctions, the ladder-like appearance. Those are examples of desmosomes, which can be identified with squamous cell carcinomas. Okay. Next, we also have another slide for squamous cell carcinoma, which is slide 152. Okay, so it's similar to slide 70. What you would see would be what's the arrangement of the squamous cell in squamous cell carcinoma. They are arranged in nests. Okay, so they are arranged in nests. If we're going to use a tumor marker for this, we are going to use cytokeratin, CYTOKERATIN. So again, we would see the presence of these nests. These are composed of squamous cells. Okay, so this is a mitotic figure. Okay, so that's a mitotic figure. Okay, So next we go to slide 187. Slide 187 is basal cell carcinoma. Okay. So basal cell carcinoma, it is a malignant lesion that would be derived from the skin. I'm going to turn it around. Okay. So the basal cell carcinoma is associated with the skin, so we always would look for a connection. So in this case, we see a connection, okay, between uh, the lining epithelium and this particular area. Basal cell carcinoma would be composed of nests. As you can see here, you would see the presence of nests. It's like looking at the map. Okay. It's composed of nests of atypical cells. There. Okay. And the cells here would be composed of basaloid cells. It is associated with the PTCH gene mutation, especially when we have the Gorlin syndrome. Gorlin syndrome would refer to the presence of multiple basal cell carcinomas with other tumors. So, what are the features for basal cell carcinoma? The nest of basaloid cells, the presence of we see the presence of the peripheral cells of the nest to be oriented radially in a palisading manner. So again, this is what we call as peripheral nuclear palisading. So we have the nest of basaloid cells, you have peripheral nuclear palisading, and there is retraction. Okay? There's a retraction space separating the nest from the stroma. This is what we call as retraction space. So this is basal cell carcinoma. So more commonly we would see it in the area of the nose. Okay, but we can identify it with other sun-exposed areas. Okay, and our last slide for this session is malignant melanoma. Okay, so malignant melanoma is, again, this is derived from the skin. You look at the lining epithelium, which is stratified squamous, and then this would be the area that would show the malignant lesions or malignant cells. So, malignant melanoma, in 85 to 90% of cases, it is sporadic. So, it is derived from ultraviolet light exposure, more commonly seen in fair-skinned individuals. And in other cases, it is associated with mutations with BRAF or BRAF, with PTEN, with RAS. So grossly, it is more than 1 centimeter. So we always see a lot of our moles or benign nevus. But if they are larger than 1 cm, they have irregular borders. You have the presence of variation in their color, like being purple to black to brown. And then it is getting larger. Consider it to be a melanoma. So a melanoma would be composed of large melanin-producing cells. Okay? So very characteristic because when we see the melanocytes, they always would have the presence of these melanin pigments. They are dark, or in this case, they are brown, and they are large cells. If we want to identify them, we can test it for the human melanin black. Okay, that is HMB45 as well as S100 for further evaluation if this particular tumor. Okay, so those are the slides that we are going to discuss. or we have discussed for today. I hope that you would have a safe night, and kindly stay safe, and had a good night to everyone.